Research Spotlight. Morphometric Study of the Sternum, Dry Bone Analysis. Introduction. The sternum is an elongated, flattened bone located in the anterior midline of the thorax, forming the front of the thoracic cage. It slopes downward and slightly forward, is anteriorly convex, posteriorly concave, and broadest at the junction with the first costal cartilage. It narrows at the manubriosternal joint, widens at the fifth costal cartilage, and then narrows again. The sternum protects thoracic organs and provides attachment for muscles. It consists of highly vascular trabecular bone enclosed by a compact layer, thickest in the manubrium between clavicular notches, and contains hemopoietic bone marrow, making it a common site for bone marrow aspiration. The sternum has three parts: the manubrium, prosternum, body, mesosternum, and xiphoid process, metasternum. The manubrium is trapezoid with a jugular notch, articulating with the clavicle, sternoclavicular joint, and the first costal cartilage, first chondrosternal joint. The body is flat, elongated, and articulates with the manubrium, manubriosternal joint, and xiphoid process, xiphisternal joint. Its lateral edges have facets for costal cartilage articulations. The xiphoid process varies widely in size and form, remaining cartilaginous until around age 40. The sternal angle, or angle of Lewis, is a transverse ridge useful for rib counting and anatomical landmarks, including the aortic arch, tracheal bifurcation, and superior heart border. The sternum develops from 6 ossification centers, 1 for the manubrium, 4 for the body, and 1 for the xiphoid process. Fusion of sternal segments is variable, typically completing between ages 16 to 25. Morphometric studies show sex-specific differences, with males having longer and narrower mesosternum than females. Rules like Hurtel's law and the 149 rule provide guidelines for sex determination, though population variations exist. Recent studies indicate that sternal morphometry can vary across populations, impacting clinical procedures such as median sternotomy. The present study aims to evaluate the morphometric characteristics of the sternum in adult Bangladeshi individuals. 1.2 Rationale. Morphometric knowledge of the sternum is of great significance in different clinical practice, like cardiac, vascular, and thoracic surgery. It considers the fact that midline splitting of the sternum is the most commonly used method to access mediastinal structures. The sternum is also commonly punctured during bone marrow aspiration. An elongated xiphoid process can be mistaken for an epigastric mass, which can be painful on palpation. When this surgical procedure is performed, the sternum is sliced through in the midline between the jugular notch and the xiphoid process, allowing access to the anterior mediastinal organs, particularly the heart and main blood veins. Dehiscence of the sternotomy closure, which results in the separation of the sternum halves and the development of deep mediastinitis, is a very uncommon but significant complication. The incidence rate is between 0.5 and 2.5%, however other research indicate that it might be as high as 8%. Suture dehiscences are impacted by a variety of parameters, including suture technique, osteoporosis degree, sex, comorbidities, and a variety of perioperative and postoperative conditions. The sternum's clinical relevance is also evident during cardiac resuscitation operations. Sternum fractures are a frequent complication of active compressive-decompressive cardiopulmonary resuscitation, a CDCPR, or artificial breathing and heart massage. Fractures acquired during this treatment may result in serious cardiac damage, which often result in death. Sternum fractures are more prevalent in females over the age of 50, according to cadaver studies. Apart from osteoporosis, the primary reason causing fractures is believed to be the female sternum being much thinner than the male and hence more prone to fractures. With the amazing range in sternum size and form, it is extremely likely that deviation from the conventional sternum may also impact the incidence of sternal dehiscence and increase fracture susceptibility. Despite the fact that the morphometry of several organs and components of the skeleton is well established, data on the sternum's morphology and morphometry remain deficient. Therefore, in my study, dry ossified sternum has been taken for further evaluation of morphometric analysis. Objective of the study. General objective: to determine the morphometric measurements of sternum. Specific objective: to measures the 1. Length of manubrium 2, width of manubrium 3, thickness of manubrium 4, length of sternal body 5, breadth of sternal body 6, thickness of sternal body 7, length of xiphoid process 8, total sternum length 9, sternal angle, anatomy of sternum, gross anatomy of sternum, The sternum, often known as the breastbone, is placed in the anterior thorax near the midway and is made of 3 parts. 1. The manubrium is the superior most part of the sternum that articulates with the clavicle to produce the sternoclavicular joint. 2. The sternum's body, or middle section, acts as the anterior attachment for ribs 2 to 7. 3. The xiphoid process refers to the inferior point of the sternum, which is fashioned like a sword. 1.4.1 A. Manubrium. The manubrium is the thickest and strongest part of the sternum, making it the most probable place to survive inhumation. It is large and thick at its superior boundary and gradually becomes narrower as it approaches its inferior articulation with the mesosternum. Superior border has a suprasternal, jugular, notch in the center and lateral oval facets for synovial articulation with the clavicle. On occasion, tiny facets may be detected on the upper boundary between the jugular and clavicular notches, indicating the location of the suprasternal ossicles articulation. Each of the manubrium's lateral borders is defined by a depression for articulation with the first costal cartilage above, a primary cartilaginous joint, and by a tiny demifacet for articulation with the upper half of the second costal cartilage below, a secondary cartilaginous joint, a synovial joint. The front surface is generally smooth, convex in the direction of travel, and somewhat concave in the direction of travel. It has 2 ill-defined lateral hollows behind the clavicle, from which the pectoralis major muscles originate. Between these hollows, the vertically slightly elevated region creates a T-shaped ridge with a transverse thickening that runs between the clavicular facets. Thus, the thickest component of the manubrium is the area between the clavicles, which is responsible for absorbing stresses sent from the upper appendicular to the axial skeleton. The sternocleidomastoid muscles originate in the front of the manubrium, superior to the pectoral muscle attachment. Both the sternohyoid and sternothyroid muscles adhere to the posterior surface, which is generally smooth and concave in both directions. Borders. The superior border is the thickest and presents at its center the jugular or presternal notch. On either side of the notch is an oval articular surface. It is directed upward, backward, and lateral-ward, for articulation with the sternal end of the clavicle. The inferior border is oval and rough, which is covered in a fresh state with a thin layer of cartilage, for articulation with the body. The lateral borders are each marked above by a depression for the first costal cartilage and below by a small facet with a similar facet on the upper angle of the body. It forms a notch for the reception of the costal cartilage of the second rib. Between the depression for the first costal cartilage and the demifacet for the second is a narrow, curved edge, which slopes from above downward and medial-ward. Clavicular notch. The upper corners of the sternum are occupied by clavicular notches. The manubrium articulates with the right and left clavicles at this point. Jugular notch. The jugular, suprasternal, notch is the superior edge of the manubrium's midline notch. Costal cartilage. Costal notches are located inferior to the clavicular notches on both sides of the manubrium. These notches correspond to articulations with the first rib's costal cartilages. The manubrium and the corpus sterni share articulation for the second ribs. 1.4.1 B. Body of sternum, mesosternum. The body or gladiolus is the longest sternal portion. It has 2 surfaces, anterior and posterior. It is flat on the front, pointed upward and forward and defined by 3 transverse ridges which cross the bone opposite the 3rd, 4th, and 5th articular depressions. The pectoralis major joins to it on each side. At the intersection of the 3rd and 4th halves of the body is sometimes visible an aperture, the sternal foramen, of different size and structure. The posterior surface is somewhat concave and similarly characterized by 3 transverse lines. It is less conspicuous than in front. Arum its lower section, on each side, the transversus thoracis takes origin. Sternal angle. The sternal angle, alternatively referred to as the Lewis angle, Ludovic angle, or manubriosternal junction, is a synarthrotic joint produced by the articulation of the manubrium with the sternal body. In surface anatomy, the sternal angle is a perceptible clinical marker. The sternal angle, which ranges between 162 and 168 degrees in men, corresponds to the approximate level of the second set of costal cartilages that connect to the second ribs, as well as the level of the intervertebral disc between T4 and T5. The sternal angle may be palpated at the T4 vertebral level in clinical applications. Data AK, 2009. Each outer border contains a tiny facet at its superior angle, which, when combined with a similar facet on the manubrium, provides a cavity for the second rib cartilage. Underneath this are 4 angular depressions that receive the 3rd, 4th, 5th, and 6th rib cartilages. The inferior angle features a tiny facet that, in conjunction with a matching facet on the xiphoid process, produces a notch for the 7th rib cartilage. These articular depressions are separated by a series of curving interarticular intervals that gradually decrease in length from top to bottom and correspond to the intercostal gaps. The majority of the cartilages that comprise the genuine ribs articulate with the sternum along the lines of their primitive component segments junctions. This is seen in several other animals, where the bone fragments stay separated for a longer period of time. The sternal angle, which varies around 162 degrees in males, marks the approximate level of the second pair of costal cartilages, which attach to the second ribs, and the level of the intervertebral disc between T4 and T5. In clinical applications, the sternal angle can be palpated at the T4 vertebral level. Symbol: the sternal angle is used in the definition of the thoracic plane. This marks the level of a number of other anatomical structures. 1. The start and end of the aortic arch, the division between the superior and inferior mediastinum. 2. The lower margin of the superior vena cava. 3. The crossing of the thoracic duct. 4. The bifurcation of the trachea. 5. The bifurcation of the pulmonary trunk. 6. The drainage of the azygous vein into the superior vena cava. 7. Thymus gland, in some cases, position of the deep cardiac plexus. 8. Junction of the intra and extra pericardial parts of the superior vena cava. Line of junction between C4 and T2 dermatome. Transverse ridge. The transverse ridge begins at the level of the second costal cartilage and serves as the reference point for all costal cartilages and ribs. The sternal angle is located between the 4th and 5th thoracic vertebrae just opposite the intervertebral disc. Xiphisternal joint. The xiphisternal joint, or xiphisternal symphysis, is a point on the sternum's body where it meets the xiphoid process. It is characterized anatomically as a synchondrosis and functionally as a synarthrosis. This joint may persist until adulthood, but normally ossifies to produce a synostosis between the two sternal components. 1.4.1 C. Xiphoid process. Metasternum. The xiphoid process, also known as the xiphisternum or metasternum, is a tiny cartilaginous outgrowth of the lower part of sternum that is normally ossified in adults. At the level of the 9th thoracic vertebra and the T7 dermatome, the xiphoid process is regarded to be 1.5 ossification of sternum. The sternum originally consists of 2 cartilaginous bars, situated one on either side of the median plane and connected with the cartilages of the upper 9 ribs. Of its own side, these 2 bars fuse with each other along the middle line to form the cartilaginous sternum, which is ossified from 6 centers: 1 for the manubrium, 4 for the body, and 1 for the xiphoid process. The ossific centers appear in the intervals between the articular depressions for the costal cartilages, in the following order: in the manubrium and first piece of the body, during the 6th month; in the second and third pieces of the body, during the 7th month of fetal life; in its 4th piece, during the 1st year after birth; and in the xiphoid process, between the 5th and 18th years. The centers make their appearance at the upper parts of the segments, and proceed gradually downward. To these may be added the occasional existence of 2 small episternal centers, which make their appearance one on either side of the jugular notch. They are probably vestiges of the episternal bone of the monotremata and lizards. Occasionally some of the segments are formed from more than one center, the number and position of which vary. The first piece may have 2, 3, or even 6 centers. When 2 are present, they are generally situated one above the other. The upper being the larger, the second piece has seldom more than 1. The third, 4th, and 5th pieces are often formed from 2 centers which are placed laterally. The irregular union of which explains the rare occurrence of the sternal foramen, or of the vertical fissure which occasionally intersects this part of the bone, constituting the malformation known as fissura sterni. These conditions are further explained by the manner in which the cartilaginous sternum is formed. More rarely still, the upper end of the sternum may be divided by a fissure. Union of the various centers of the body begins about puberty and proceeds from below upward. By the age of 25 they are all united. The xiphoid process may become joined to the body before the age of 30, but this occurs more frequently after 40. On the other hand, it sometimes remains ununited in old age. In advanced life, the manubrium is occasionally joined to the body by bone. When this takes place, however, the bony tissue is generally only superficial, the central portion of the intervening cartilage remaining unossified. Gray's anatomy, sternal variation. Suprasternal or episternal or suprasternal bone. Suprasternal or episternal ossicle is a small accessory ossicle at the superior margin of manubrium that results from supernumerary ossification centers. It can be unilateral or bilateral. Suprasternal tubercle. Suprasternal tubercle forms when a suprasternal ossicle fuses with manubrium. Similar to suprasternal bone, it can be unilateral or bilateral. Manubriosternal and sternociphoidal fusion. Manubriosternal and sternociphoidal fusion can be partial or complete. It is best seen in sagittal and oblique coronal planes. Complete fusion can be seen in younger and older patients. Manubriosternal fusion in the older age group due to degeneration can be associated with bridging osteophytes. Inflammatory arthritis, especially ankylosing spondylitis, can lead to similar fusion of manubriosternal joint. But this pathological ankylosis can be differentiated by its clinical features, involvement of other joints, including sternoclavicular joint and spine, and biochemical markers. Sternal and xiphoid foramen. Sternal foramen occurs from incomplete fusion of a pair of sternbrae. It can be single or multiple and is usually seen in lower part of the sternal body. Identification of such variations is important to prevent fatal complications during sternal marrow aspiration and acupuncture. Since mediastinal structures are unprotected, complications like cardiac tamponade can occur. Similarly, xiphoid foramen can occur, but is of lesser clinical significance. Sternal cleft and band. These vertically oriented midline congenital defects are seen at the junction of the sternal bars. Sternal cleft occurs due to failure or incomplete fusion of sternal segments. Bands are generally found in the manubrium and sternal body, but not in the xiphoid process. Sclerotic band in sternal body is usually seen in the inferior segment in the midline and can occasionally be associated with sternal cleft or foramen. Although sclerotic bands are more common than cleft, they usually have no clinical significance. Sternal defect or notch. Focal defect or notch is usually seen in lower one-third of the body of sternum in the posterior aspect. Anthropological importance of sternum. The sternum located in the middle of the anterior thoracic cage is often used in forensic anthropological contexts as being a flat bone that can survive a great degree of compression. The sternum is one of the bones that are used to determine sex on a wide range, either by direct measurement of dried sternum bones from corpses or indirect measurements of images taken from chest radiographs. This attributed to that the sternum may be preserved in an integral form even in the case of massive skeletal destruction, because of its relatively protected position in the body, so studies performed on it may be more beneficial than the other bones of the body. The sternum has attracted significant interest in studies of sexual dimorphism. In addition to the use of sternum to determine the sex, it was also used to determine age and height in forensic examinations. Many studies analyze the applicability of Hurdle's law to determine the sex from the sternum, which states that the length of the mesosternum is more than twice the length of the manubrium in both males and females. Clinical importance of sternum. When the need arises, inspiration and expiration can be increased greatly by actively changing the volume of the cylinder. When exercise, flight or fight responses, or other physiologic conditions demand increased respiratory performance, the accessory muscles of respiration respond to increase the diameter of the chest on inspiration and decrease the diameter on expiration. These changes, along with increased respiratory rate, allow a tremendous increase in respiratory gas exchange so the body can compensate for increased demand. Changes in the position of the skeletal components of the chest wall cause the changes in the dimensions of the chest. Two very different types of motion of the ribs and sternum create these changes in diameter. Anteriorly, the ribs are connected to the sternum, which can be viewed as a handle on a mechanical water pump that is activated manually. High in the chest, at the manubrium, the handle has little motion, so its upward and anterior excursion is relatively limited. The joint between the manubrium and the body of the sternum allows the body and the xiphoid process to have a greater anterior and cephalad excursion, which causes the lower ribs to move more cephalad and anterior than the upper ribs, resulting in a greater increase in diameter in the lower chest. The accessory muscles of inspiration cause these increases in thoracic diameter, which result in forced inspiration. Conversely, the accessory muscles of expiration cause the sternum to move downward and inward, decreasing these diameters and causing forced expiration. Articulation. The cartilages from ribs 1 and 2 articulate with the manubrium, but the cartilage from rib 2 also articulates with the body of the sternum. The main articulations with the body of the sternum are with cartilages 2, 3, 4, 5, 6, and 7. The upward and outward movement of these cartilages causes the greatest increase in the internal diameter of the chest. The lateral projections of the sternum show where the clavicle and all the cartilages from the ribs articulate with the sternum itself. The sternal movement is greatest at this joint. The angulation between the manubrium and the body of the sternum is called a sternal angle. This angulation forms the bucket handle that moves upward and outward, with the superior end of the manubrium being relatively fixed. Muscle attachment. Manubrium. The anterior surface gives origin on either side to the pectoralis major. The sternal head of the sternocleidomastoid. The posterior surface gives origin to the sternohyoid in upper part, the sternothyroid in lower part. The suprasternal notch gives attachment to the lower fibers of the interclavicular ligament and to the two subdivisions of the investing layer of cervical fascia. The margins of each clavicular notch give attachment to the capsule of the corresponding sternoclavicular joint. The body. The anterior surface gives origin on either side to the pectoralis major muscle. The lower part of the posterior surface gives origin on either side to the sternocostalis muscle. Between the facets for articulation with the costal cartilages, the lateral borders provide attachment to the external intercostal membranes. Internal intercostal muscles. The xiphoid. The anterior surface provides insertion to the medial fibers of the rectus abdominis and to the aponeuroses of the external and internal oblique muscles of the abdomen. The posterior surface gives origin to the diaphragm. The lateral borders of the xiphoid process give attachment to the aponeuroses of the internal oblique and transversus abdominis muscles. The upper end forms a primary cartilaginous joint with the body of the sternum. The lower end affords attachment to the linea alba. 1.11 Blood supply. The major source of branches to the sternum is the internal thoracic or mammary artery, ida. It originates from the subclavian artery. It descends 1 to 2 centimeters from the lateral margin of the sternum adjacent to the posterior aspect of the chest wall, partly covered by the transversus thoracic muscle from the 3rd to the 6th costal cartilage. Sternal branches are intersegmental, located in the intercostal spaces and form arcades at the lateral edge of the sternum. This reflects the intersegmental location of ossification centers that are supplied by sternal arteries. Arteries reach the anterior and posterior aspects of the sternum, feeding into dense periosteal plexuses, which are better developed on the posterior side. The plexuses are segmentally organized in infants, corresponding to sternbrae, but are confluent craniocaudally in adults. Harvesting the ida for coronary bypass will disrupt sternal circulation to a variable extent, although this hypoperfusion may be temporary in most cases. When the ida is dissected, any branches should be ligated as close as possible to the main vessel in order to preserve collateral branches. Likewise, sternal cerclages should be placed as close as possible to the sternal edge to preserve the arcades between sternal arteries. 1.12 Nerve supply of sternum. The sternum and manubrium are innervated by the intercostal nerves, which are part of the somatic nervous system. These nerves arise from the anterior rami of spinal nerves from segments T1-T11. The first two nerves supply the proximal sternum and manubrium. 1.13 Histology of sternum. Sternum is a flat bone. In flat bones, compact bone is formed at both the internal and external surfaces due to a marked predominance of bone deposition over bone resorption, whereas a spongy pattern remains in the central portion. The endosteum and periosteum are formed from layers of connective tissue that are not undergoing ossification. Cancellous bone. Cancellous bone is composed of numerous bony trabeculae separated by the marrow cavity that contains blood vessels and different types of blood cells. Bony trabeculae are lined by a thin inner layer of cells called the endosteum. Osteoprogenitor cells in endosteum give rise to osteoblasts. Formed bone matrix contains numerous osteocytes in lacunae. The large, multinuclear osteoclasts are eroding or remodeling the formed bone matrix. Osteoclasts erode part of the bone through enzymatic action and lie in the eroded depressions called the Hauschup's lacunae. Compact bone. The structural units of a compact bone matrix are the osteons, Haversian systems. Each osteon consists of layers of concentric lamellae arranged around a central, Haversian, canal. Central canals are shown in cross-section and in oblique section, middle leader. Lamellae are thin plates of bone that contain osteocytes in almond-shaped spaces called lacunae. Radiating from each lacuna in all directions are tiny canals, the canaliculi. Canaliculi penetrate the lamellae, anastomose with canaliculi from other lacunae, and form a network of communicating channels with other osteocytes. Some of the canaliculi open directly into central, haversian, canals of the osteon and the marrow cavities of the bone. The small irregular areas of bone between osteons are the interstitial lamellae that represent the remnants of eroded or remodeled osteons. External circumferential lamellae form the external wall of a compact bone, beneath the connective tissue periosteum, and run parallel to each other and to the long axis of the bone. The internal wall of the bone, the endosteum along the marrow cavity, is lined by internal circumferential lamellae. Osteons are located between the internal circumferential lamellae and external circumferential lamellae. In a living bone, the lacunae of each osteon house osteocytes. The central canals contain reticular connective tissue, blood vessels, and nerves. The boundary between each osteon is outlined by a refractile line of modified bone matrix called the cement line. Anastomoses between central canals are called perforating, Volkmann's, canals. Materials and methods. Materials. Study population. This study was performed on dry fully ossified human right humerus collected from Department of Anatomy, Medical College. Fulfilling the inclusion criteria. Selection criteria. Inclusion criteria. Dried ossified, apparently normal human sternum. Intact manubriosternal joint. Exclusion criteria. Presented with sternal foramina. Bifid, perforated xiphoid process. Sample size. By reviewing existing literature and consulting with expert, the present study was performed on 200 dry adult human right humerus. Data collection. Data was collected by using pre-designed data collection sheet prepared for the study. Research instruments. Measuring tape, vernier caliper, protractor, metallic scale, digital camera, preformed structured data sheet. Methodology. Study design. It was a descriptive study. Place of the study. Department of Anatomy, Sylhet Mag Osmani Medical College, Sylhet. Sampling method. Purposive sampling technique. Method of data collection. This study will be conducted on dry ossified sternum collected from Department of Anatomy, Medical College, Sylhet, fulfilling the inclusion criteria. Procedure of data collection. Procedure of measurement of manubrium length. Measured by distance from the center of the suprasternal notch to the center of the sternal angle. Procedure of measurement of sterna body length. The maximum distance from sternal angle to sternox xiphoid symphysis. Measurement of length of xiphoid process. Measured by maximum length from sternox xiphoid symphysis to the inferior xiphoidal end. Procedure of measurement of width of manubrium. The manubrial width and thickness is measured just below the clavicular notches and just above the sternal angle, and an average value will be obtained. Kiram et al., 2020. Procedure of measurement of thickness of manubrium. The manubrium thickness measured on 2 points which represent extreme values of manubrium thickness. The greatest thickness measured at the intersection of the central longitudinal line and the line joining central points of clavicular notches. The least thickness is determined at the point where the central longitudinal line intersected manubrium at the middle of its length. Selthofer et al., 2006. Procedure of measurement of width and thickness of mesosternum. The width and thickness of the mesosternum determined at the 2nd, 3rd, 4th, 5th and 6th intercostal notches and averages value computed. Measurement of total sternum length. Total sternum length is the distance measured from the jugular notch to the xiphoid process end. Measurement of sternal angle. While measuring the sternal angle, the sternum will be set down and fixed in the lateral position at the right angle. On the underground below the sternum, next to the sternum posterior surface, the points will be marked immediately below the sternal synchondrosis, manubriosternal joint, next to the lower end of clavicular notch and below the lower end of the 4th costal notch. The sternal angle is determined by drawing lines to join the points marked on the underground. Sternal angle will be measured with a protractor. 3.2.7 Variables of the study. Maximum length of manubrium, maximum width of manubrium, thickness of manubrium, maximum length of sternal body, maximum breadth of sternal body, thickness of sternal body, length of xiphoid process, total sternum length, sternal angle. 3.2.8 Data processing and analysis. After completion of data collection, the data collection form will be rechecked and verified to reduce error. Necessary correction will be done before computer entry. Finally, data will be processed and analyzed with the help of a computer based on SPSS, Statistical Package for Social Sciences, software program, version 22.0 for Windows. After entry into computer, results will be analyzed according to objectives and variables of the study. The summarized data will be presented in the form of tables with necessary interpretations and inferences. Both descriptive and inferential statistics conducted for this study. 3.2.9 Ethical consideration. Prior to the commencement of the study, an approval of the research protocol will be obtained from the ethical committee. Results. Manubrium measurements, Table 1, Fig. 1. The mean length, width, and thickness of the manubrium were greater in males than in females. The mean length was 50.66 plus or minus 9.57 mm in males and 46.28 plus or minus 8.52 mm in females, showing a significant difference. P equals 0.017. The mean width was 50.86 plus or minus 12.17 mm in males and 41.48 plus or minus 10.57 mm in females. P equals 0.002. The mean thickness was 11.29 plus or minus 2.68 mm in males and 9.19 plus or minus 2.48 mm in females. P equals 0.022. These findings indicate that all measured dimensions of the manubrium are significantly larger in males, reflecting sexual dimorphism. Body of sternum, Table 2, Fig. 2. The mean length, width, and thickness of the body of the sternum were also higher in males than in females. The mean length was 93.84 plus or minus 23.31 mm in males and 82.84 plus or minus 14.80 mm in females. P equals 0.001. The mean width was 35.30 plus or minus 10.83 mm in males and 29.22 plus or minus 9.65 mm in females. P equals 0.004. The mean thickness was 19.86 plus or minus 9.91 mm in males and 16.12 plus or minus 7.39 mm in females. P equals 0.034. Thus, the body of the sternum exhibits clear sexual dimorphism, with all parameters significantly greater in males. Xiphoid process, Table 3, Fig. 3. The mean length of the xiphoid process was 22.39 plus or minus 3.43 mm in males and 19.20 plus or minus 3.78 mm in females, with the difference being statistically significant. P equals 0.001. This confirms that the xiphoid process is generally longer in males. Sternal angle, Table 5. The mean sternal angle was 148.29 degrees plus or minus 8.24 degree in males and 149.32 degrees plus or minus 9.69 degree in females. The difference between the two sexes was not statistically significant. P equals 0.443. Therefore, the sternal angle shows minimal variation between males and females. Discriminant function analysis, DFA, Table 5 and 6, DFA parameters such as intercostal width of mesosternum, sternebrial width index, and minimum breadth of manubrium were all higher in males, with statistically significant differences, p less than 0.05. The analysis correctly classified 79% of sternums by sex, males equals 79.2%, females equals 78.8%. Upon cross-validation, 76% of cases were accurately assigned. These results demonstrate that morphometric characteristics of the sternum can reliably differentiate between male and female specimens in the Bangladeshi population. Discussion. Morphometric values of the sternum are essential in anatomy, forensic science, and archaeology. They also aid clinicians in bone marrow aspiration and biopsy procedures. The present study was conducted in the Department of Anatomy, Sylhet Mag Osmani Medical College, to determine morphometric parameters of the dry, fully ossified sternum, and the results were compared with previous studies. Manubrium. The mean length, width, and thickness of the manubrium were 49.14 plus or minus 5.05 mm, 45.93 plus or minus 6.65 mm, and 10.56 plus or minus 0.95 mm, respectively. These findings are comparable to studies from India, China, and other countries. Atesolu et al., 2018, Sharif et al., 2018, Buhay et al., 2002. Regional variations likely reflect population differences in body build and stature. Body of the sternum. The mean length, width, and thickness of the body were 89.91 plus or minus 10.31 mm, 30.1 plus or minus 5.04 mm, and 9.47 plus or minus 0.19 mm, respectively. These results closely align with Chinese data. Buhay et al., 2002, and are slightly lower than values reported in African and Western populations, Yang et al. 2014, suggesting ethnic variation in sternal dimensions. Xiphoid process. The mean length of the xiphoid process was 19.40 plus or minus 3.60 mm, consistent with previous reports. Akin et al. 2011, Xie et al. 2014. Total sternal length. The total mean sternal length was 157.76 plus or minus 12.78 mm, similar to results from Indian and Chinese populations but shorter than those observed in Western samples. Bongiovanni and Spradley, 2012. Sternal angle. The mean sternal angle was 145.86 plus or minus 5.98 degrees, which is close to earlier findings. Wunner et al. 2019. Kiram et al. 2014. Overall, the present study demonstrates that Bangladeshi sternal measurements are comparable to other Asian populations but smaller than those of European and African groups, likely reflecting body stature and ethnic differences. Conclusion. The sternum is a common site for bone marrow biopsy due to its larger breadth and subcutaneous position. The sternal thickness is a critical factor in this procedure as fatality incidences have been widely reported. The thickness of the sternum may also play a role in how likely it is to break in chest trauma or when moderate pressure is put on the chest, like when giving cardiopulmonary resuscitation. Sternum is the site for bone marrow biopsy due to its larger breadth and subcutaneous position. Knowledge of the morphometric values of sternum is important in forensic, anatomy, and archaeology. It is also helpful for the clinician in the treatment and biopsy purpose. Limitations of the present study. 1. The sample size of the study was small. 2. The study period was short. 3. The study were collected only from the Department of Anatomy. Silet Mag Osmani Medical College. Recommendation for further studies. Larger samples should be used to develop a morphometric standard of sternum. Sample studies on bone of different age groups, i.e., growing and osteoporotic bone, are required to draw a complete morphometric data of sternum. Measurement of different dimensions of living bones by radiographic study and compare them with the fully ossified dry bones are suggested. Thus, a morphometric comparison between living and dry bone can be made. Isolated studies on bone samples of different ethnic groups residing in different parts of Bangladesh are recommended.